All right. Hello, everyone. My name is Harrison Steins. I am a fourth year medical student here in Colorado in the United States. Today, I'll be talking about a presentation that was first shown at the Silverton Mountain Medicine Symposium in Silverton, Colorado earlier this year. And this talk is in conjunction with the College of Remote and Offshore Medicine. So you can see both those listed here. We'll be talking about austere ultrasound and tropical diseases and identification of tropical diseases and some important cases using ultrasound, as well as applications in prolonged field care, notably nerve blocks. Again, my name is Harrison Steins. I am a fourth year medical student. I've just applied to emergency medicine residency here in the United States. I'm also a master's candidate in osteocritical care at the College of Remote and Offshore Medicine. And as far as qualifications, I'm still working toward emergency medicine in many ways. At my school so far, I am a predoctoral clinical ultrasound scholar. And if you find some of my other YouTube videos, you'll see some of my other work with ultrasound. This presentation was developed in conjunction with Zach Ryan, who is additionally a medical student at Rocky Vista in Colorado with me. So a little bit more about me, fourth year med student, living in Denver, Colorado, applied to emergency medicine, doing the master's in osteocritical care. I also have a master's in biomedical science. Prior to medical school, I was working in EMS and emergency management, either in New York City or in San Mateo County in Northern California. In my free time, I love the outdoors, love living in Colorado. And most of my research focuses on resource-limited medicine, austere ultrasound applications within those settings, and lung physiology and pulmonary medicine in endurance athletes, especially as it relates to austere cases. So today, we have a couple of learning objectives. So we're going to talk a bit about the theory of ultrasound and how it can apply in soft tissue cases, and then how we can use ultrasound in resource-limited environments for diagnosis and management. And then we have some hard skills that I would like everyone to learn. And I also have some slides built in that can help you develop your own ultrasound models at home and then use some of what you find here in this lecture to move forward and practice some of the skills that you're able to learn and take away from this. So, overview. Basics of what ultrasound is. So if you're in the master's program or doing any work with the College of Remote and Offshore Medicine, you have a couple courses on ultrasound. But again, ultrasound takes sound waves, points it directly into a structure, and then structures of different densities reflect that sound wave in varying patterns. And an ultrasound in the machine uses some algorithms to pick up how much is reflected, how much is refracted, and then what sound waves are returning from what structure based on the amount of time that it takes to come back. And you can see here a little very basic demo of sending a wave out to a structure, and in this case, a curved structure, and seeing how an ultrasound wave bounces back from that curved structure. So again, moving toward the ultrasound basics, when we're looking at ultrasound moving through tissue, different pieces of the body have different measurements within that ultrasound. So on the far left here, we can see N labeled for nerve, and next to it, artery and vein. At the top of the screen, so right up here, we're seeing the very top of the skin, so most superficial, and then as you move further, it's going to be most deep. I like to think about it like a flashlight. As you point a flashlight through space, what's closest to you and closest to the top of the screen will be shown first. So on the far left there, that's a nerve. They generally present in a honeycomb pattern. And as you get more dense, so something like bone, will show up brighter. We call it hyperechoic. So it's going to be reflecting more of that ultrasound wave back to the ultrasound device. Next to the nerve, we see an artery and a vein. We know that something's a vein because it can be compressible, although some arteries, depending on where they're at, can be compressible, and depending on the amount of force that you use, can be compressible. You can use color Doppler, so looking at the flow of fluid under the ultrasound probe, either to it or away from it, and this can sometimes help you as well. Additionally, arteries will be pulsatile, so on a static image, you might not be seeing this, but keep in mind that some of the larger veins, say like a inferior vena cava, may also be pulsatile based on the presentation of the patient. So as we look at MSK, musculoskeletal imaging, things of different densities can show up as different structures. So in 3A, we see the raw ultrasound image, and then in 3B, you can see the skin, and then a layer of hyperechoic fascia, and then hypoechoic deltoid muscle, and then a bursa and supraspinatus tendon, which is showing up more hyperechoic. And then finally, at the very bottom, we see the humerus, and you can see the bright hyperechoic edge of that long bone there. So, what are we using soft tissue ultrasound for, and what are we using ultrasound for in different environments, such as resource-limited environments? They can be used to spot pathologies, look at normal. You can be looking at different types of abscesses, different infections. You can use ultrasound, which is actually generally pretty sensitive and specific for upper extremity fractures, lower extremity fractures, if you don't have other types of imaging. But we do have to remember that ultrasound is operator dependent. The ultrasound can only see what's scanned, and you must make sure that anything you're imaging is fully imaged. So if you see a lesion like an abscess, you're starting at the normal edge, scanning all the way through the lesion, and then ending at the normal edge. You can even scan a contralateral side. So say I were to see an abscess or an area of fluctuance on like a right upper extremity, I might scan the left upper extremity first and make sure that this isn't the norm. So it can also be difficult to differentiate between various types of fluid on ultrasound. For example, hematomas may resemble abscesses, and vice versa. So clinical context is important. Look at the patient in front of you and not just at the screen. And I think that generally goes for anything you're doing with ultrasound. If you're doing an ultrasound-guided procedure, look at the patient, look at where your needle is going, and not just the screen because you might miss something. So the first case that we're going to look at is a cellulitis case. So again, these are superficial infections, mostly from strep species. What do we see on ultrasound? So early cellulitis may appear with skin thickening or edematous. And as it progresses, we can start to see cobblestoning appearance as this edematous fluid accumulates between fat globules. So if it's very, very edematous and in the skin with less adipose, you may lose that cobblestoning and it may appear diffusely hyperechoic. Um, but what we can see here is that cobblestoning appearance. So each of these is part of that cobblestoning. We have, again, skin superficially, muscle deeper. So all of the green, dark green is cellulitic fluid, and then the light green is adipose. So dark green is this cellulitic fluid right here, and then this light green is adipose. So if we go back, you can take an image at that. So the next thing that we're going to be looking at is going to be a video where we're scanning through the cobblestoning, and I'll play this one more time. So I think this is a good example of just scanning the actual pathology, but on the end here, we can start to see that normal muscle tissue comes back in. So ideally, what you would like to be doing is scanning through the normal tissue all the way through the pathology and then back to normal tissue. So keep this in mind. And all of these cases we're going to go through initially will appear in some of our cases at the end, which is going to be good. So next, an abscess. So both cellulitis and abscesses can present with erythema, warmth, tenderness, swelling, and possibly and potentially induration. So I think it's important to look at your patient in front of you and then try and determine based on their clinical presentation what you have a higher suspicion for. But ultrasound can help us differentiate. So abscesses have a variety of causes, and depending on the size of the abscess, you can approach it with treatment differently. So I think that's where ultrasound is really useful. So for example, if an abscess is less than 1 centimeters, you may opt for antibiotics and just a warm compress for resolution. And again, if an abscess is present in an austere setting where you may not have the follow-up or the ability to keep something clean, you may only want to intervene if it's superficial. So what we can do is put our ultrasound probe onto an abscess, and we can look for a couple of things. The first thing would be what I call the swirl sign and what's known as the swirl sign. So the swirl sign is pulsatility or peristalsis. So essentially, pus within a space. So in here is that abscess space. And then what you would see as you press on that abscessed space is pus swirling around the inside of it. This is called peristalsis. So that's when the abscess contents are moving around in a circular fashion under the pressure of the ultrasound probe. You may also be able to use posterior acoustic enhancement if there is a significant amount of fluid with floating hyperechoic debris. So in this image, we can see there is some posterior acoustic enhancement, which is just shown as hyperechoic lines on the distal edge of that abscess or that pocket of fluctuance. So if you're going to IND the structure, so do an incision and drainage, and we'll talk a little bit about what that looks like, you want to measure it in two planes. So in your transverse and then in your coronal plane. Um, just to make sure that you're seeing all of the edges. And then the last thing that you can do is put color Doppler on to make sure that there's not an inflow of fluid into your abscess or the pocket is not actually, say, a hematoma that hasn't formed clotting yet. And if you were to cut into it, may have an active bleed. So here we have an abscess where we put on color Doppler just to make sure that if you're going to be cutting into that, you're not cutting through a surrounding vessel and that there's no pulsatility or vessel flow into that pocket of fluctuance that you're going to be cutting into. And then swish sign, swirl sign, starting in a clear pocket of fluid or a clear area and then moving into the abscessed area. And as you push on it, there you go. You can start to see the peristalsis of the purulent fluid moving around within. So if you're practicing at home or just as an intro into abscess IND, you find the abscess, find the extent of the margins, and then you can aim for your incision. So you can use a 27 gauge needle with an anesthetic solution. You can inject directly into the abscess, but keep in mind that the pH of the abscess may negate the anesthetic solution, say lidocaine. So I generally inject around both edges of an abscess so that they can't feel my needle poking around the entire abscess. You find the point of maximal fluctuance. So this is going to be the largest point, maybe the deepest point that you see on ultrasound, and then you can do a couple of different incisions. I generally make a linear incision from one point to the other and then take hemostats and break up loculations within the abscess. Once you've done that, you leave it open, let it drain, and that will allow the abscess to heal on its own without suturing it closed and capturing some of that bacteria that you've just drained out. Alternatively, you can pack it with iodoform gauze, so impregnated gauze with iodine on it, and pack all around. And when I'm electing to do this, I'll make sure that I'm really packing it and getting to every edge of that abscess. Okay, so moving on to necrotizing fasciitis, or the scale of necrotizing soft tissue injuries, NSTIs. So, um, as we can see here, the progression of a skin to mucosal breach of bacteria can start to move down to the epidermis and then move further and further to the blood supply. Once the blood supply becomes damaged, then you can get these bullae or ecchymosis and get erythema swelling and overall necrotic appearance. And then once you've moved down to full vascular occlusion, then you can get necrosis in multiple tissue layers. So this deeper tissue gets that infection. You occlude these large vessels, and then you essentially get like anoxic or lack of blood flow to that area, and it can start to necrose. In the hospital, we can use a couple of things to scale necrotizing fasciitis or necrotizing soft tissue infections. One would be the Linrix score. So these are labs that we would order for nec fasc. So say a CRP over 150, white blood cells over 15, creatinine over 1.59, or glucose over 180. Commonly, these are caused by inoculation of the tissue from bacteria, from trauma, burn, surgery, insect bites, mostly group A streps, Staph aureus. Sometimes you can see Vibrio from swimming, or it could be polymicrobial, especially in elderly or immunocompromised. In the austere setting, if you're looking at your patient, you may appreciate erythema, the subacute gas, and crepitus, although gas is a very late finding. And then early neck fasc will present with this tissue thickening that can sometimes be confused for cellulitis, but they have different treatments. So antibiotics versus debridement and big on IV antibiotics, like something like linezolid. And then you'll also see pre-fascial fluid. So what we can do is use the staph mnemonic, which is subcutaneous thickening, air, and fascial fluid when we're looking with our ultrasound at some of these possible necrotizing soft tissue infections. So if we're out in an austere environment and we don't have CT, which is the gold standard, we can put our probe on and start to see a couple of different things. So first would be that subcutaneous air, which is emphasized here. Subcutaneous air allows, it's not as dense, so it'll allow ultrasound waves to pass through, and then you can get this posterior acoustic enhancement out on the backside of the air. You'll also start to see shadowing. Finally, we'll see fluid and subcutaneous thickening from where you're getting increased erythema and swelling. So in this, the orange is fascia, and then fluid is purple. So again, using our staff mnemonic for subcutaneous thickening, which would be this thick, more superficial later, and then air, which we're not seeing as much of. You could make an argument that maybe this is some air. Um, and then fascial fluid. So again, in here, the fluid is this purple. Fantastic. This is going to be a video of scanning through. So as we move forward, you can start to see that subcutaneous air, posterior acoustic shadowing, all moving through. We're not seeing cobblestoning, which we may be confusing with cellulitis if we were just looking at the patient without the opportunity to use ultrasound. So why is this important? Let's jump into a hypothetical. So our setting is Kabosho Hospital, 150-bed hospital in Tanzania. Say we don't have some of our normal tools. I'll approach it from my perspective going into emergency medicine in the US. It might be a little bit different than here, but maybe similar to where you're working. So this could be our norm. In the United States, we have our donut of truth, our CT scanner that is present right behind many of the trauma bays. You can slide your patient right in. Someone with a necrotizing soft tissue infection or neck fash may cut the line for anyone else who's waiting for the CT, and we're able to expertly visualize it. We also have a full resuscitation bay, any of the tools that we may need, some of our other imaging modalities. X-ray might be right there, able to come in at the drop of a hat. But this might not be what we're working with in a resource limited setting. So we may have this really, really old Welch Allen defibrillator. Hopefully it's working. We have some pads with it, but you're not going to have your continuous monitoring. And the only tool we may have might be a portable ultrasound that you've brought out as part of your personal medical kit or the medical kit assigned to whatever organization has brought you out there. So with all of this in mind, we need to think about how we're going to be approaching patients and patient care and then diagnostics. So if the patient in front of us presents in this next case, how are we going to use the tools that we have in front of us to make the diagnosis? So we'll jump through a case. First, we have a 24-year-old female. She came in with 3 weeks of night sweats. Symptoms gradually progressed with an increasing abdominal pain localized to the right upper quadrant, 6-day history of abdominal swelling. Important to note, 24 hours prior to the presentation, she began to have postprandial vomiting, fever, and an inability to pass stool or flatus. Her previous bowel and urine habits were normal. She reports bouts of diarrhea approximately once every month for the last year. And then the diarrhea was treated with over-the-counter antibiotics with symptom resolution. And her only medical history is she's a newly diagnosed diabetic just about 2 months ago, and her only medication is insulin. So here are her labs or her vitals. BP 86 over 70 or 87 over 65, pulse 114, respirate 29, pulse ox 98, and temp 38.2. So looking at these, some things that are notable, she's decently hypotensive, tachycardic with an increased respiratory rate. So I'm thinking that she could have some sort of infection based on these symptoms. She's generally sick appearing, pale jaundice, diffuse lymphadenopathy with moderate pitting edema. Her cap refills prolonged. She's got weak peripheral pulses and a temperature gradient. Precordium's hyperactive without any extra sounds. JVP's flat. So this is already giving me a picture that she's pretty sick. In terms of sick or not sick, I'm going to say that this patient's going to be sick. She's no acute distress on respiratory exam. She does have tachypnea, but nothing else noted. Her abdomen is grossly distended. She has marked global tenderness with light palpation localizing to the right upper quadrant where it was before. She has a enlarged liver span of 18 centimeters, negative Murphy sign, no shifting dullness or fluid or thrill, and reduced bowel sounds. She has moderate pitting non-tender edema bilaterally. So on our differential diagnosis for this person in this tropical setting where we have minimal tools, we're thinking of a couple of different things, all thinking about things that are making us believe she's sick. So we could be thinking about acute choledocholithiasis or cholecystitis, hepatic or pancreatic tumor, intestinal obstruction. She's not passing gas. Is this an SBO? Salmonella typhi infection, given the scenario and where we're at. Does she have a liver abscess or a perforated ulcer? So we don't have the opportunity to grab some labs at this moment. We're just in this rural hospital with only what we see in that crash cart. Maybe the opportunity for some point of care labs, maybe a CBC, CMP if you wanted, and you can get a EKG. But we do have our handy dandy ultrasound right there with us. So we're going to take a look. Fortunately, we have a great radiologist with us, and I'll give you some of this information off the bat. So her chest X-ray was normal. Her CBC had a white blood cell count, leukocytosis. So white blood cells of 16 with the neutrophilia. Hemoglobin was normal at 10, normocytic, normochromic, and a platelet count of 236. She had a BGL of 97, and her liver function tests had a bilirubin level 3 times normal and mainly conjugated. And ALP and AST were 2 times normal. Neg for Hep B and C, malaria and HIV. So when we put our probe on, what do we end up seeing? So this is a right upper quadrant ultrasound that we see no appreciable fluid in the abdomen or pleural space. We do see a large solitary mass in the right lobe of the liver. It has mixed echogenicity, meaning that you see hypoechoic area right here, and then you see hyperechoic area kind of all throughout this deeper edge of that liver. So we see distinct borders abutting the diaphragm. So based on this image, what do we change our differential diagnosis to? Now that we actually have some imaging, we know the labs. So we can narrow this down to an amoebic liver abscess with sepsis based on the patient's presentation with that leukocytosis, her respiratory rate, her tachycardia, and her blood pressure. I believe her stolic was pretty low. We can also think that she may have a pyogenic liver abscess or a metastatic or primary tumor with hemorrhagic transformation or co-infection. So this was a real case. What ended up happening was the woman got an X-lap. She had a ruptured liver abscess, and then the abscess was drained, and she was given antibiotics. She was given metronidazole in this case. Her diagnosis was amoebic liver abscess, peritonitis, and septic shock. So going over our ultrasound image and the pathology as a whole, this was caused by Entamoeba histolytica. So amoebiasis is one of the most common infections worldwide, affecting up to 10% of the entire population. Most often caused by a protozoa called Entamoeba histolytica, which spreads with fecal-oral transmission, mainly through contaminated food and water, but it can also be sexually transmitted. Mostly causes intestinal disease, but you can get some extraintestinal manifestations. The liver is the most common extraintestinal organ affected. So they're most common in men ages 18 to 50. And essentially, once the cysts are ingested, they germinate into trophozoites, which then can attach to the intestinal epithelium, while some invade to the colon and can spread to the liver and the peritoneum. So they cause hepatic inflammation, necrosis leading to formation of an abscess, generally developing within 2 to 4 weeks. So just like with our patient, we saw some fever, dull epigastric or right upper quadrant pain and nausea. They can progress with diarrhea, constipation, vomiting, distension, weight loss, or even a dry cough from diaphragmatic irritation. So thinking about all of the symptoms that we could be getting by upsetting what's in our abdominal cavity or in our thoracic cavity, messing with that diaphragm. So ultrasound has been a key method of diagnosing amoebic liver abscess, and new recommendations encourage point-of-care ultrasound. It's also used to track the resolution of the abscess during treatment. Sorry. So the abscess is most commonly found in the right upper lobe of the liver as a solitary peripherally based mass. So as you can see here, we see a pyogenic liver abscess that has these irregularly thick walls. You do see posterior acoustic enhancement because you don't have a normally echoic structure throughout. You do see that mixed echogenicity. You also see a lack of vascularity. So on color Doppler, the center is typically avascular. That's because that infection is kind of walled off where these vessels are. So once we found that, we can start to progress to, if we're in an austere environment, give this patient the antibiotics that may most commonly treat Entamoeba histolytica, which would be metronidazole. Or you can use these results for ultrasound-guided biopsy, which typically yields this kind of characteristic anchovy sauce color and consistency. If you have access to additional resources, you can use CT, MRI, or stool analysis and ELISA. And then treatment is really dependent on the size of the abscess. So while we're able to get the initial size with measurements with our ultrasound, we can also track that resolution and then make decisions on our treatment. So here's a case of where ultrasound in the backcountry or in an austere and resource limited environment proved to help us make the diagnosis in the context of what was happening. So say in the US, this amoebic liver abscess wouldn't necessarily be my first choice on my differential, or I'm not sure if it would actually even make it onto my differential. But given the context of where we were in this setting of our hypothetical, you can start to think about some of these other more tropical disease causes. And same if a person came into the emergency department in the US or in Colorado and had a history of this recent travel, then we could start to think about that as well. So, okay, so our next case, we have a 7-year-old male, has a chief complaint of fever and diarrhea, worsening diffuse abdominal pain and weight loss over the past 2 weeks. He was traveling to Honduras about 3 weeks ago. So out of these, what's the number one thing that stands out to me? And I would probably say the weight loss over 2 weeks. So you don't really ever want to be seeing weight loss in pediatric patients, and significant weight loss over 2 weeks is very, very concerning in this case. So here are his vitals. BP of 117/75, pulse of 110, respiratory rate of 18, pulse ox of 100, and temp of 99.7. And sorry for whoever's watching this for the conversions. But if you're like me, every time you'll probably have to pull out your pediatric vital signs charts as well. So generally, patients appearing dehydrated, dry heaving, heat is normal, cardiac's normal, respiratory is normal. He does have a soft, mildly distended, and diffusely tender abdomen with no guarding, no rigidity, no palpable abdominal mass, but he does have hyperactive bowel sounds, so they're really moving there. So for a 7-year-old male coming in with fever and diarrhea and abdominal pain with weight loss, what's on our differential? We can think about inflammatory bowel disease, gastroenteritis, colitis, not necessarily colorectal cancer based on the person of this size. You can also think about, say, Meckel's diverticulum, although he would be on the outer edge of when that would happen. Intussusception would definitely be something as well, although you may experience pain a little bit differently. And the fact that he's experienced this weight loss is interesting as well. Additionally, like a small bowel inflection, small bowel obstruction. So we put our ultrasound on and we're able to see a couple of different things. We see transverse abdominal images showing a loop of bowel containing multiple small diameter right here. So this is our loop of bowel. Again, superficial, deep loop of bowel, multiple small diameter circular structures with isoechoic wall and a hypoechoic lumen. These structures represent interluminal parasites in the cross section. So fortunately, we had our amazing radiologist, or hopefully you after this presentation, to recognize that. So again, we have our loop of bowel and then multiple small diameter circular structures, isoechoic wall, hypoechoic lumen, isoechoic wall, the same as the outside, iso meaning same, hypoechoic lumen, darker on the inside. We also received some lab information. His CXR was normal. His CBC had a leukocytosis of 16 with neutrophilia. Hemoglobin was normal at 10 and platelet count of 236. Negative for Hep B, C, malaria, and HIV. So take our initial differential diagnosis, and now that we've gotten some imaging back, we can narrow it down to an intestinal nematode infection, food content, Crohn's disease, UC, Meckel's diverticulum. Based on the patient's presentation and history with his travel to Honduras in the last 3 weeks, and this starting about 2 weeks after that, in real life they concluded that he had a parasitic infection. He was given albendazole, which is an antiparasitic, 100 milligrams, 2 times a day for 3 days, and he cleared the infection without issue. Diagnosis was Ascariasis lumbricoides. So, what is Ascariasis? And I think that this is a really, really interesting, pretty advanced disease state ultrasound showing the tubular structure with the echogenic walls in a dilated small bowel. So this is the actual parasite. So essentially what ends up happening is the adult small intestine ingests this larva, and then mostly through ingestion of water or food contaminated with the eggs. These then migrate to the lungs and the upper respiratory tract as larvae, and then they are coughed out, eventually swallowed again as they're coughed. They kind of sit where that epiglottis is, and they'll be swallowed into the esophagus and develop into the small bowel where they change into adults. So it's a largely asymptomatic infection that's initially or incidentally identified on routine endoscopic procedures or radiologic imaging. But in symptomatic patients, they usually present with high worm loads. So common symptoms can include intestinal obstruction because of the mass of parasites within that structure, eosinophilic pneumonia, aka Loeffler syndrome, hepatobiliary injury, or pancreatitis. So in this case, small bowel ultrasonography was a very rapid and non-invasive tool that can be used to diagnose these intestinal parasites. You use a high-frequency linear probe in a long section, and adult worms appear as paired echogenic bands separated by anechoic area, so almost like railroading tracks, which you can kind of see here. This is the uh, hypoechoic area with a hypoechoic lumen separated too. In a cross-sectional view, as we saw before, they can be seen as an echogenic ring shadow, often described as a bullseye or target sign. So moving on to our next case. We've looked at some parasitic cases, but now we have a 64-year-old male coming in with atraumatic right foot pain, swelling, and drainage for a week. History of insulin-dependent diabetes and hypertension. So initially, based on his history, I'm thinking, okay, do we have a diabetic that has a diabetic ulcer that they haven't felt? Are they walking around without shoes on? What's the overall diabetes care for this patient? He's had drainage and swelling for 1 week, so when we look at his vital signs, he is hypertensive, he's tachycardic, respiratory rate of 16, pulse ox 96, and temp slightly elevated at 106. So this person could be considered septic. Generally, he's comfortable, no evidence of trauma. He's pretty dry, possibly from the diabetes, but possibly from something else. He's tachycardic, no murmurs, rubs, or gallops. Respiratory is cleared auscultation, soft and non-tender abdomen. His ANO times 4. He has a small necrotic toe, an open wound on the right foot with purulent drainage, and no crepitus noted, and no pain out of proportion. So I'm going to show the image now of what his foot might look like, and this is taken from a real case that was seen in an orthopedic clinic. So we can see some area of erythema marked by a Sharpie. And then we can see some area of skin injury on both the pinky toe and then on the bottom of the foot. So in a patient like this, concern for osteomyelitis, concern for how deep some sort of infection is going, and we get a differential of cellulitis, abscess, non-necrotizing soft tissue infection, osteo, septic arthritis, DVT. In this clinic, we do have a X-ray, and our radiologist was kind enough to point out subcutaneous air noted on their plain films. We then take our ultrasound out to it, and using our staff mnemonic, we're looking for a couple of different things. If we're looking for NSTI, and looking for cobblestoning if we're looking for cellulitis. I'll give you a couple labs while you take a sec to look over that. So he had a normal chest X-ray. Again, he had a leukocytosis that was pretty high. Blood sugar was normal. So what do we end up seeing here? We see some cobblestoning with dirty air and gray shadowing. So we don't see fluid here, but maybe we see some subcutaneous thickening. So the ST in our staff mnemonic. And do we see some air? So moving forward, the point of care ultrasound demonstrated subcutaneous edema. So this thickening here, known as cobblestoning. You can see it all here because it looks like a cobblestone street. And hyperechoic artifact within the soft tissue with dirty gray air shadowing and A lines, which you can see here and probably here, but it's easier to see in moving image, consistent with subcutaneous emphysema. So this was our initial differential diagnosis, and now that we've taken the image, we've based it on, or we've narrowed it down to a necrotizing soft tissue infection and cellulitis. What ended up happening, this person got a course of vancomycin, piptazo, zosyn, and clindamycin. Podiatry was consulted and immediately, and the patient was admitted to the SICU, and he got a Chopard's amputation. So he's discharged home post-op. So I think in an austere setting, for someone who's diabetic who may not have feeling to their feet, they have diabetic peripheral neuropathy, this would be really important to be able to understand the extent of their injury without further imaging like a CT scan. So for someone with an NSTI, we're worried about a rapidly progressive infection. So these are generally polymicrobial infections with considerable mortality ranging between 20 to 75%, especially when the diagnosis is missed or delayed. So necrotizing soft tissue infections are a scaled item. So you can have an STI of the epidermis and dermis, which are known as cellulitis. If it is spread to the subcutaneous tissue, that's known as fasciitis. And if it's spread to the muscle, that is myositis, so necrotizing myositis. Um, so the diagnosis is generally pretty challenging given a physical exam, and symptoms may vary from asymptomatic people, like this what our patient probably came in with, to septic shock. So diagnosis based on physical exam alone misses actually surprisingly up to 60% of cases. So for our patients, we're looking at the person in front of us. Local findings include edema, ecchymosis, hemorrhagic blisters, bullae, crepitus, or tissue necrosis, but these are often seen very late in the infection. Typically, the classic finding of pain out of proportion is also absent. So therefore, it's imperative to maintain a high index of suspicion, especially in a place where you have limited resources or you are the only care and the person may not get follow-up care. So we can have classic laboratory findings, including a leukocytosis, hyponatremia, and lactic acidosis. And in the hospital, you can use the Linares criteria to aid in diagnosis. Plain films similarly have some sensitivity of less than 50%. Presently, CT is the standard of care, given its sensitivity of around 94%. Treatment is adequate resuscitation, early administration of broad spectrum antibiotics and fluid if they're in a septic state, typically depending on the microbiology. Vancomycin, piperacillin, tazobactam, and clindamycin can be used. And he should get an immediate surgical consultation. So as far as our tools go, data is limited for point-of-care ultrasound, but it appears to be an effective means to expedite the diagnosis and treatment of an STI, especially in the resource-limited setting without access to CT. So the sensitivity of POCUS can approach 90%. We want to use our high-frequency linear probe. And then again, we're seeing kind of those staph signs. So characteristic findings include thickened subcutaneous tissue or fascia, fluid along the fascial plane, and subcutaneous emphysema. And then be sure to compare the affected side to the unaffected side. So I know this is a lot. Now that we've gone through this entire kind of background, let's put ourselves into an area. So you are working on a team. You have a doc, nurse, and a medic in a resource-limited clinic. You have 16 hours to ground transport to a tertiary care center. No flight is available. This is what your clinic looks like. So this is the entrance. This is your treatment area. You have a couple of these. You have your backboard and some drugs set up on the back. But overall, it's pretty rudimentary. So we're in the backcountry. We're thinking about how we're approaching patients. We want to go beyond March in this case. So our initial approach to patients in prolonged field care and rescue, your massive hemorrhage, airway, respiration, circulation, and hypothermia. We are now at the stage 2. We've done our initial assessment of the patients, and now they've come to our clinic. We want to use all of our diagnostic approaches and stay within the prolonged field care bounds, which is essentially a practice guidance to guide casualty management over a prolonged amount of time in an austere, remote, or expeditionary setting, or during long distance movements. So prolonged field care often talks about the minimum, better, and best methodology. So what is the minimum you need to do your job? What is a better solution? And what is the best solution that you could get in, say, a tertiary care facility, or say like a forward operating surgical base? If you're in like a resource limited environment. So as far as monitoring, we start to think about our minimum is you need a BP, stethoscope, pulse ox, and possibly a Foley to monitor urine output and organ perfusion. Better would be capnometry, and best would be a fully fledged vital signs monitor. As far as resuscitation, we often talk about in the initial approaches, say in March, having fresh whole blood. And then better would be 2 to 3 cases of LR for burn resuscitation and still sticking with that blood for massive hemorrhage and penetrating or blunt trauma. And then best would be a mix of everything that you could need. So PRBs, FFP, and type specific donors to be able to replenish your supply. As far as sedation and analgesia, we go through our opiates titrated through IV. Then you can get sedation of ketamine with the option of midazolam for your better, and then educated, practiced, and well-informed for all of your multi-drug sedation as your best. Physical exam. Our minimum is our physical exam. Maybe you have a stethoscope, and I contest that all of these should be used in, all of the minimums should be used in the better and the best as well. Better, ultrasound and point of care labs. So we've gone through our march for an emergency. We've stabilized a patient as best as we can do so, and now they arrive to our clinic, which we saw earlier. We then want to go through our prolonged field care, and a mnemonic to remember this is HITMAN. So we do our head to toe exam, reassess the patient. We think about infections and what's in a longer term period, so not just the first hour or golden hour, what's going to hurt a person or kill them over the next 12 to 24 hours, or however long we need to hold them in our prolonged field care, resource limited setting clinic that we have. Think about tubes. We want to make sure that we're securing tubes, replacing air and cuffs with water, putting on capno, changing IV sites every 24 hours. Medicines, we think about analgesics, antibiotics. So if someone's coming in with some penetrating injury and we've cleaned it up, we want to start some of those antibiotics, monitor the drug levels, monitor the levels of inventory of what we have, and then document things. Administration, making sure that documentation is up to date, and making sure that we are all safe. And then finally, nursing care. It's not going to be the immediate infections that are developing over the next 24 hours that are going to hurt your patient. But if your patient's got an infection on their back and they're not turned every couple of hours, or they have an infection around their mouth with a laceration and they're not getting proper oral care, then that might start to hurt them. So back to our clinic. We have, again, our doc, nurse, and our medic in our clinic. We have a 16-hour ground transport, and we have some supplies. So in terms of prolonged field care, this is our setup on the back wall. We've got our life pack there. We have a safe tube vent, and we have our ultrasound. We have our bag. So if you're a medic or a physician, PA, NP, whatever it is, looking through, the amount of medications we have are not very plentiful for our clinic here. So we have like 2 grams of TXA, we've got 250 mics of fent, some midazolam, some morphine. We have a decent amount of lidocaine and some bupivacaine, so we can figure out how those are going to help us. And then we have overall just not that many supplies that if someone were to come to our clinic and then need to leave, we're not exactly sure how we would start to help them. So what's going on? We have an accident that came in. So it was 14 minutes after the shift change. Everyone left. You're not getting those team back. They're out on vacation. So you have your 3-person team and 1 ALS transport ambulance, and they don't have any drugs. So you just have the drugs that you're going to use. You have a rollover with 4 patients. One's walking wounded, one's penetrating chest that's stabilized, one has a pelvis fracture, untriaged, and one has a right lower extremity injury that's untriaged. More on the way. You're unsure of the nature of their injuries or how many are coming. So we need to think about how we're going to use our supplies and how we may use some of our resources, such as our ultrasound, to assess the patients and figure out what we want to do. This talk is going to transition from our tropical diagnosis with ultrasound to now how are we actually using ultrasound to affect change in our patients and form care plans. So, damn, your team crushed March, they crushed the resuscitation, and now you have all of your patients. So in the first hour, you have your walking wounded that's stable. Your penetrating chest trauma was stabilized. He has a chest tube draining to a vac. Got 1 rib fracture that you're able to see on your ultrasound. You don't actually have X-ray there. He's hemodynamically stable though. You have 1 pelvis fracture. Motion testing's positive, so you hear some crepitus and feel some movement. Hemodynamically stable now. Currently, EFAST is negative, so there's no fluid in the abdomen, in your right upper, left upper, or pelvic regions, and there's no fluid around the heart. Lungs are up as well. he does need emergent transport. And then your lower extremity injury has an anterior thigh laceration with a right femur fracture that needs emergent transport. So we have all of these, and we need to get our patients out of there. We have the drugs that we have, and that's it. So when we think about the area that we're going to be transporting and the area that maybe some of you transport in resource limited settings, this may be what it looks like. This is the pothole that we're seeing. And if you think that this is going to be a very smooth, stable ride, your patient's just going to lie on a nice fluffy bed, this is more so what it's looking like. So with every pothole you see and every part of the extrication, you're going to be thinking about your patient's pain. And you're going to be thinking about some of these movements may exacerbate the injuries that they have. So how are you going to approach getting your patients packaged and ready to go? How much of each medication do you have? How much fent do you have? And how much midazolam Versed do you have? Um, and think about the logistics of you know more patients are coming, you don't know exactly what's going on with them. So how are you going to start to manage your patients? So we've got some fentanyl, morphine, ketamine, ibuprofen, and acetaminophen, and we don't have all that much of any of these. So what's something that we could think about using our ultrasound and using some of the supplies that we have, including lidocaine and bupivacaine, to get these patients out of here? And I know you were thinking it too, but I was thinking about nerve blocks. So when we think about nerve blocks in resource limited settings, I think that it's very useful to utilize ultrasound as our tool to identify the nerves, identify the structures around where we want to inject, and then go from there. So here's just a couple studies on some of these nerve blocks. So pre-hospital ultrasound-guided nerve blocks improved reduction feasibility of dislocated extremity injuries compared to systemic analgesia. So this was an RCT that looked at these pre-hospital ultrasound-guided nerve blocks that were performed rapidly in extremity injuries with high success. So we know that we can have success in getting the nerve block solution, so the lidocaine, bupivacaine, ropivacaine, your drug of choice, to that area, and that they do reduce pain and intensity and severity. So this was a feasibility study seeing who could actually do these. So additional education for EMS nurses showed that they were able to successfully perform these fascia iliaca compartment blocks, providing acute pain relief to patients with suspected femur fractures. And then finally, we're able to see that these iliaca compartment blocks used as pain treatment were very successful in compared to some of our other uh, pain management tools. So in this study, all 27 patients received a block, and then 108 had standard pain treatment, which was either IV morphine, alfentanil, ketamine, or some benzos in conjunction with all of that. So there was more significant reduction in pain groups, but there was a more marked reduction in pain groups among those who had received the fascia iliaca compartment block than in the control group. So for static pain, so non-moving, 56% experienced a reduction in pain in the block group versus 30% in the controls. And then for dynamic pain, much like we might see in our moving ambulance, for the block group, it was 85% reduction in pain as opposed to 59% in just the standard pain control. So I think this is very, very interesting in an austere and resource limited environment, something that we can definitely start to think about. So what is a nerve block? We use a needle and a syringe to deliver local anesthetic near nerves to impede the pain signals from reaching the brain. They're acting on sodium channels and acting as a sodium channel blocker. So when a nerve tries to depolarize, it's not able to. Why use a nerve block? They can be used for everything from digital anesthesia for suture repair, or local anesthesia for pain management and fractures and procedures. So why use an ultrasound in them? So you can actively watch your needle in real time. And when I was talking earlier about watching your patient and the monitor at the same time, you do want to be watching where your needle's going into your patient, and then you can also be watching it on the screen. So you can see the anesthetic infiltrate around the target. So if we have a specific nerve and we want to do a fluid bath around that nerve so that we're able to encompass the entire area in between the fascia, so that we bathe the entire nerve in anesthetic, we can watch that in real time. You can avoid intraneural injections. So if you know where a nerve is, you want to avoid actually going into it. You can avoid transecting your nerve with your needle. You can avoid intravascular anesthetic injection, and it requires less sticks for success. So again, how do we identify nerves? So these honeycomb appearance that we can see in this axial image here looks almost like a honeycomb. And we can see a nerve in a longitudinal plane here. We look at it in both an axial and longitudinal plane because nerves maintain their honeycomb appearance and their caliber, so the diameter, the entire way you're going up. Whereas vessels, say veins, might change in their caliber, especially if two vessels are approaching, say, a um, a valve. Always do a negative aspiration to ensure you're not in a vessel. So, what do we need? We want a 18 to 20 gauge needle to ensure visualization on the ultrasound. It's small enough not to cause a lot of pain. Could use a spinal needle if you have a larger habitus. You only need 5 to 10 cc's for a peripheral nerve block, and for a compartment block, fascial plane block, generally 20 to 30 cc's of fluid. I think depending on the area you're trying to block, that will allow you to figure out how much anesthetic you need. So if you have one finger that you're trying to block, that's going to need much less anesthetic than, say, an entire femur. So you also have your anesthetic, appropriate size needles, gloves. Sterile is not necessarily necessary, but I would recommend sterile for a nerve block. So drape the patient, get them all clean, don sterile gloves, put a probe cover onto your ultrasound probe, and then go in if you're going, especially into like a hip block or something like that. For lasting pain, you can go with bupivacaine or ropivacaine, which last a little bit longer. For quick repairs, or you need someone to be ambulatory, you can go with lidocaine. We'll elaborate more shortly. So, a note on anesthetics for lidocaine versus ropivacaine versus bupivacaine. Ropivacaine is actually the least cardiotoxic. So if you're doing any blocks close to the chest or blocks in large volumes, you may opt for that. Bupivacaine is the longest acting, between 4 and 18 hours, and lidocaine is the shortest acting, between 1 and 3 hours. So if you're doing a quick repair of a laceration, generally go with lidocaine, as it has also the quickest onset. You can have an epi additive, which will hasten the onset and enhance nerve uptake due to the decreasing of local blood flow, and it slows clearance of anesthetic from the nerve. Adding epinephrine also reduces or also increases the total volume needed for lidocaine toxicity. So I would say when you're also doing a nerve block, you can use some of these apps like Safe Local from Johns Hopkins, or MBCalc to calculate the overall volume that you can be putting into someone without needing to worry about lidocaine toxicity. Some of the risks that we see are hematomas, infections, limb injury, nerve injury, neuritis. And then we can see LAST, which is local anesthetic system toxicity. And this is something that we get very concerned about. Um, So last is overall toxicity, and some things that people could start to see are a sense of impending doom, altered mental status, perioral sensation. So if they start to get a alternation in taste or paresthesias or numbness of their lips and tongue, then start to think about systemic toxicity. Um, the death comes from a prolonged QRS and heart block. Because these anesthetics are working on sodium channels, they can disrupt the conduction system. So you treat it with 20% intralipid or fat emulsification, which can be important to know that you need to have your reversal agent. So, time to block. We'll go quickly through this, as I know this is a pretty long lecture. But we have a 72-year-old male backpacking. He gets a report from a through hiker that he slipped and fell, denies hitting his head, but he mentions excruciating pain in his right hip. When you get there, you see a low cloud ceiling, gusty winds, and it's looking like a long wheeled Stokes out of there. It's going to be very, very bumpy. So we need to be concerned that this patient has possibly a hip fracture. You see his outturned hip here. What can we end up doing? A fascia iliaca block. So this is great for femur fractures, anterior thigh injuries, large abscesses in this distribution. And given this example, take this to your resource limited setting for someone coming in with a prolonged transport time, or someone coming in that needs generally more pain control that you're able to give them. Also, if you're worried about needing to reassess their alter or their mental status or mentation, and you don't want to load them up on opioids so that they're so snowed that they can't talk to you, think about some blocks like this. So this blocks the femoral and lat fem-q nerves, and potentially the obturator and GF nerves as well. And it can be standard of care for your hip fractures. So you can set your targets, so the ASIS and inguinal ligament, and you're going to be going 2/3 of the way away from your inguinal ligament, and 1/3 of the way closer to your ASIS. You're watching out for your femoral nerve, your femoral artery, and your femoral vein. As you approach with the ultrasound, you can start to see the needle is guided here, um, avoiding the lateral femoral cutaneous nerve, punching through fascia iliaca, coming close to your iliopsoas muscle, which you can see right here. And this is an alternating image. And then you're finding your femoral nerve. And you can start to see, you can bathe around that area. So here again, we can see our muscles. We can see sartorius. We can see our iliopsoas right here. This is our nerve. This is our femoral artery. I always recommend that you approach it at an angle that you're not going to be abutting femoral artery on the back. So if we're coming down here, we want to be deep to our femoral artery, and then you can start to bathe around the nerve. So it's most easily identified, the femoral nerve, just lateral to the femoral artery and vein. It's on top of this iliacus muscle, so as in pectineus. And it's separated from the femoral artery by the fascia iliaca. Um, you can do two approaches, suprainguinal or infrainguinal. The suprainguinal has better evidence for efficacy. So you advance inferior to superior, identify the deep circumflex artery to avoid it. And then you want to see unzipping of this fascial plane. So what I mean by that is as you start to inject the lidocaine or the solution, you want to see those fascial planes coming apart from each other. You can feel for two pops of fascia, so the lata and then the iliaca with the needle. Sometimes people talk about three pops. Once you've felt those pops under your needle, and some needles have an actual pressure sensor with them, then you can spread that anesthetic under the fascia iliaca to cover the obturator, femoral, and the lateral cutaneous femoral nerve. Shown to have better pain control than oral analgesia alone, and better ambulation at 1 year. Next, we can see about our popliteal sciatic block. Same for this leg injury. It's great for leg injuries below the knee, large abscesses in this distribution, lack repairs, and we block the sciatic nerve. We only use about 20 cc's here, and it only misses the medial leg and foot coverage, which is given by the saphenous nerve. So as we can see here, we're coming down to our popliteal artery and vein pretty deep. And then we have our needle, which is actually not present here, coming down as a lateral approach to the sciatic nerve. Okay, again, another scenario. You have a 24-year-old climbing trip patient. She took some big whip. She has right side of her torso impacts a ledge. She's in pain. She's tachypnic. Shallow respirations, bracing right anterior chest wall. First, we're going to use our ultrasound to know that she doesn't have a pneumo. We see positive lung slide in all quadrants. We do think, and we do notice that she does have this step off right here, which we can note as a rib fracture. We can use our ultrasound to approach a lateral or a serratus anterior plane block. This is great for anterior lateral rib fractures. It's used in mastectomies and chest tubes. Doesn't include pleural plane, but we can block the anterior branch of the lateral cutaneous nerves nerves T2 through T9. And we got to watch out for the lung. So the goal of this is a fascial plane block between latissimus and serratus muscles. We have the patient lie on their side in lateral recumbent or in the supine position. And then in plane, we can approach anterior to posterior or body habitus dependent at the fourth intercostal space. We identify the thoracodorsal artery in the plane with color Doppler before injecting. So in this image, we can see our thoracodorsal artery here, and it may be in here in this image, but we don't have color Doppler on, so we can't necessarily see that. We want to avoid hitting any arteries when we're doing some of these plane blocks, so you can aspirate as you're going through. So the anesthetic will expand in the cephalad and caudal direction among the plane, and not necessarily anterior and posterior. So this will affect rib above and below. So our needle comes in from an anterior to posterior approach in between these two muscles. And then we separate both the latissimus dorsi and the serratus anterior, and then we coat the area in anesthetic. Additionally, if we see a posterior injury, we can approach with a erector spinae block. It's great for posterior rib fractures. Doesn't, again, include pleural plane, vertebral compression fractures, or chest wall injury. And this blocks the entire erector spinae, so the iliacostalis, longissimus, and spinalis muscles. And it actually spreads 3 to 4, sometimes 5 dermatomes above and below the injection site. It involves the abdominal wall, but not the anterior chest, due to intercostal nerves. The mechanism of action of why it affects so many dermatomes above and below isn't fully understood, but it's proposed that it's anterior diffusion into the paravertebral space and likely towards the posterior rami of the spinal nerves. So what we end up doing is starting 2 centimeters lateral of midline, as you see on this patient here. So midline, we're going to say at the spine, 2 centimeters lateral. Fan laterally to find the rib, and fan medially to lose it and find the next bony structure. We can insert the needle in the cranial to caudal plane until we contact a transverse process where it meets the rib. So we're coming from the top to the bottom, going in 2 centimeters lateral to midline and contacting the transverse process of that spine, where it meets the rib. You will only see rhomboids to T5 and then they end. So sometimes you might not see these 3 levels of muscle here. And then you're going to inject 20 to 30 cc's between the erector spinae muscles in the transverse process. So we've done a couple of back blocks, we've done a hip block, and now we have something else. So this is one of our skier friends, was crushing it in Rocky Mountain National Park here in Colorado, where I live. Dropped in too early before the sun worked its magic, didn't have any of that awesome corn that he was looking for, washes out, attempts to grab a tree, arrests his fall. Here's a pop. Lands on his left arm that's injured. He has severe angulation above the wrist, severely diminished distal pulses, and his hand's getting colder. So what do we end up needing to do? Because we have the diminished pulses, this is an emergency, and so we're going to need to reset this. So say you're out in our resource-limited hospital. Someone has come in, got their hand stuck in a door. Someone fell out of a car. Someone got hit by a car or run over. The same thing could happen. What you could end up doing is a supraclavicular brachial plexus block. This is good for the entire arm except the axilla. So for like fractures, lacerations, abscesses, AV fistula revisions, not necessarily in the scope of this, but this is a very risky procedure. As with everything in this talk, I want you to approach it within your scope, under your medical direction, and at the level that you're trained at. And none of these should be done on live patients until you've actually had the training under a supervising physician or your supervisor. So the pleura is very close to what you're injecting here, as well as some very large nerves and your subclavian artery, which you can see right here. So what we're going to do is look above the clavicle, just superior to the first rib. Be sure to identify the subclavian, and then find a slice of pizza, which, if you use your visual imagination right here, this is our slice of pizza. That is the brachial plexus. There's 2 approaches that you can take. You want the patient to turn their head away. Approach laterally to medially with the probe parallel to the clavicle. Locate the big pizza slice, brachial plexus, the middle scalene, which is right here, and subclavian artery, thing that you definitely do not want to hit. You can perform 2 passes injections because the nerves are separated by fascial planes. So the first will be a superficial pass where you're approaching opposite side of the artery and injecting first above the first rib, 10 cc to cover the lower cords. And then you're going to pull back and not just fan through because you'll transect some of the nerves. And then your second injection will be in the middle of the other 5 cords, or right on top of the brachial plexus with another 10 cc's. Okay, gone through a lot of blocks and just a couple of left. Forearm blocks, these are great for hand injuries. Coverage is dependent on the nerve distribution. These are going to be smaller injections, generally 3 to 5 cc's, and will likely hit all 3 distributions. As far as the median nerve, which we can see the distribution here, their first, second, and part of, and third, and part of your 4th finger. So these are good for palmar lax or abscesses in the hand. Your radial nerve, I like to think of rad, given a thumbs up. So it's going to be your thumb, dorsal hand distribution. These are good for dorsal hand lax and abscesses. And then your ulnar nerve distribution, these are good for 5th metacarpal and boxer's fractures. So again, here we're starting to see where things are kind of broken up. This hyperechoic honeycomb structure in each of these is seeing your nerves. So your median and your radial and your ulnar. Hand injury algorithm. Minor injuries, you can start low. We want to start kind of right around what we're seeing. You can use any of your three blocks, index to thumb, index and middle and ring fingers. You can use your radian and medial. And then your boxer's fractures, you can use your ulnar blocks. So as far as blocks go, I start in either the lateral to medial or the medial to lateral direction based on what nerve you're trying to hit. Again, these are smaller. You can start mid-forearm between the flexor carpi radialis, which is superficial, and the flexor pollicis longus, which is deep. Find your nerve, and then you can go ahead and inject. As far as radial nerve blocks, similarly, this is just deep to brachial radialis, and extends our carpi longus and brevis muscles. Depending on where you're at, you can see your superficial and supinator muscles. Inject mid forearm to ensure you're capturing the proximal innervation of the thumb because this actually bifurcates pretty early. So you want to make sure that you're able to get that entire nerve bundle before the bifurcation. Sometimes you can actually inject it at the elbow. You can start at the wrist side and slide proximal to watch this neurovascular bundle separate to the nerves and radial artery. And then approach it again on the opposite side of the artery. So we see the artery here, approaching it on the opposite side so that we're not going to transect or inject into the artery. Finally, our ulnar nerve block, great for dorsomedial or medial palmar hand lacs or abscesses. It's between the flexor digitorum superficialis, flexor carpi ulnaris, and flexor digitorum profundus at the deep end. So we're going to find our ulnar artery, see our ulnar nerve coming from the same side, and then again do a fascial plane block where we're separating the fascial planes. At home, what I want you to do is look up this study. You can look it up right down here called Ultrasound-Guided Regional Anesthesia Simulation and use of meat. So you can actually take a couple pieces of meat, take some yarn, and soak the yarn in ultrasound gel, and this is very important to practice all of the skills that we talked about here today. So if you go home, take your ultrasound, I want you to take a large needle, maybe an 18 or a 16 gauge needle so that you can really visualize it. Look up this paper and start to build it. And then utilize this as your practice page. So practice finding what a brachial plexus looks like, not actually injecting anything into here, and then finding what a median nerve looks like with all of the parts of it below. I think this is going to be great for practice, not actually for injecting on anyone, but just identifying the nerves, seeing if you can identify neurovascular bundles, as well as arteries, bones, tendons, and how muscle looks compared to everything. So I know that this was a very, very long lecture. Thank you for this and for being here with me. Excited. If you have any other questions, you can email me. My email is e.steins@corom.edu, and that's my College of Remote and Offshore Medicine email. And it was great being here with you today. And thank you so